That's for the EPU, but the problem is, they get a very nice, what we call salary as well as good living standards. And in Sri Lanka, practicing emergency medicine is not the easiest thing because it's hard work. You have to be there, you have to answer the calls. And again, emergencies, it's always actually this is a rush. So only people who can, tolerate admin rush can do emergency medicine. People like me, rather do nephrology rather than emergency medicine. So it's also challenging. So we need the fullest support for the emergency physician. And as an introduction, because we have never had emergency medicine. So she will give us a nice introduction to the emergency medicine. And the topic today will be redefining the effort and approach to assessment of the critical ill patient, which I don't know, but I'm going to learn from you. Thank you very much. Thank you.
Thank you, Dr. Udana. So first I will discuss about the theory part and then we'll discuss about the specialty because I didn't prepare for that part and this is more important. So today we are revisiting the kindergarten, I would say, talking about alphabet. But that is the primary basis of managing a patient with critical illness. So that is very important to know. So before knowing how to manage, we have to know who is a critically ill patient. So critically ill patient is one who is presented with altered physiology. He got some problem, some pathology which we don't know, and that pathology has led to alteration of his normal physiology. So he will be coming with altered physiology. Can be due to breathing system, can be due to circulation system, we don't know. But our main aim is to identify the deteriorated physiology and stabilize it and then find the cause. Because in the traditional medicine, if we discuss about, first we go for a cause, but here the life matters, the time is life. So we identify the altered physiology, we fix it, then we will be finding the cause for the altered physiology. So that is the critically ill patient. So as I said, initial treatment is aim is to keep the patient alive, not to find the cause, just to stabilize, and then we can find the cause. That is a part of the resuscitation. So this we call as blueprint. I'm sorry about the poor image quality. So blueprint is the protocol we use to analyze a critically ill patient. First thing is triage, then initial stabilization, then third part is directed history and examination, then commence specific treatment and ongoing care. So you can clearly see triage is, I will talk about triage in a minute. So first we'll identify this patient is critically ill, then we initially stabilize. Then only we will be going for directed history and examination and find the specific cause and treatment. So triage, what is triage? So we are going to talk about disaster management as well as the latter part of this lecture. So triage is getting the right treatment at right time to the right patient in the right place. So everything has to be right to save the life. So triaging is very important. If we discuss in further, this is the A&E guideline suggested triage sheet. So if we elaborate more, these are the life-threatening emergencies. Like we won't be measuring any blood pressures or pulse oximeter or anything at triage if patients are presenting like this, like cardiac arrest, respiratory arrest, ongoing seizures, intubation on arrival, and respiratory distress with gasping kind of breathing, which means like imminent death. So don't waste time on triaging and sort of get immediately to the bed and connect to monitors. And I'm just describing about triage. Then these are imminent life-threatening conditions where you can record a set of vitals at presentation. Acute chest pain, most likely cardiac origin. This is not a patient who is coming with chest pain for 2 weeks. This is a one who is coming with pale, diaphoretic, and very sick. We know that this is impending cardiac arrest kind of chest pain. And violent behavior, very aggressive towards patient, other patients as staff as well. Major trauma, that is a separate entity when it comes to emergency medicine. Severe pain, severe intoxication, can be snake bite, can be other thing. And acute MI stroke, like prime critical management. These patients get a set of observations at triage and immediately needs to escalate treatment. So those triage categories, depending on the clinical presentation, we categorize. But these are the numbers we check for to categorize them under category 1, 2, 3, 4. So all doctors should know about these categories because like it is widely spoken thing. So somebody says like Cat 2 patients, we should know as a doctor. So this is how we categorize and why it is important. So depending on the category, it indicates the severity of the illness and how quickly do we need to intervene. So Cat 1, it's red. So immediately this patient is like about to die. So immediate intervention. Cat 2 patients, they are imminently life-threatening. You need to attend within 10 minutes. We have to stabilize this patient. Then Cat 3, well, they will be like walking and talking patients. Their physiology is stable, but if we don't treat, they will go into unstable category. That is category 3. So they are stable, but if we have to treat, otherwise they are going into Cat 2. So we take like 20 minutes to attend. They can wait, to be honest. If a Cat 2 patient comes and Cat 3 patient comes together, we have to attend the Cat 2 first. So that is the message of trial. Right patient, right time. And Cat 4, they are clearly like OPD kind of patients where they are having some illness and they need treatment, but they are not critically ill. Okay, so that is about triage. So we are coming to our original topic. So management of critical ill patients. So when you see a critical ill patient, what will happen to you? What do you think?
Become angry. I become angry.
This? Because you are renal, so you become anuric. Or this? Kind of both, isn't it? Yeah. So that is very natural response because a patient is kind of dying in front of us. So definitely we will be anxious. So that is why we need to have a standardized approach to stabilize these patients. So in an emergency, we all are panicking. So most important thing, don't panic. If you get panic, you can't help your patient. So keep it chill, keep it cool. I only panic if I can't find my stethoscope, otherwise I'm not. So don't get panic if you see an emergency patient. You are the best person who can treat that patient at that time until help arrives. So if you are a house officer, you are the best one at that time. If you are RHO, if you are SHO, you are the best one at that time. So within your capabilities, you can help because it's basic. That it's like ABC. And most importantly, sometimes, especially at PCU level, we make sure you wear PPE sometimes because we see a couple of like intoxication patients like OP poisoning, carbamate. So I have quite often seen they are quickly running and attending to patients without even PP, and these patients are vomiting and everything is on our clothes and everything. So don't get yourself into trouble as well. Just make sure you wear some PPE if indicated. Okay, so stabilization, when we discuss about stabilization, there are three components. One thing is positioning of the patient, then A to E approach, then MMR. So we will elaborate more. So this is about the patient's positioning. Usually a critically ill patient, they do arrive in the best position they can cope up with. So if a patient having a breathing difficulty, you will see they will be always seated. If you try to make him lie supine, he will resist. So don't disturb them. Their bodies are trying to keep their body alive. That is the take home message, to be honest. We cannot treat, we just support and support their physiology so they can recover. So don't disturb them. If they are coming like a shock patient will be lying flat. When you try to make him seated, he will be like fainting, not feeling well, diaphoretic and sort of. So make sure, just observe them, how they are, and just keep them comfortable. If a child coming with breathing difficulty, seated on mother's lap, don't take the child out. Definitely, it will worsen symptoms. So these are a couple of examples. This first picture is a breathing difficulty patient who is in a propped up position. Then a pregnant one, we know we have put on left lateral because of the gravid uterus. There is IVC compression. So left lateral position is preferred. And pediatrics, of course, keep with their parents. They are very comfortable with parents then, especially sick kids, they are always scared. So keep them comfortable. And the other patients are like shock patients. Give patients in supine position and elevate the limbs because you can increase the venous return. Okay, so what are ABCD? Any guesses? Really? I thought it's just first 5 letters of alphabet, no? It's different, no? Yeah, you are correct. So it's airway, breathing, circulation, disability, and exposure. So why ABCD? As I previously described, the classical medical examination like approach is history, detailed history, then we do a detailed examination, investigation, diagnosis, treatment, and reassessment. So that is quite correct in a stable patient. That is the approach from a broad point of view. But if the patient's physiology is impaired, we have to save the life before patient dies. So this won't help. So we have to go for killer sequence. So killer sequence is luckily matching with our alphabet as well. So even if we are panicking, we can remember ABCD. So airway, breathing, circulation, disability, they are killer sequences. That is the killer sequence. So make sure you attend accordingly, right? So airway. So very difficult to describe on the entire airway management. So even the breathing and circulation. So I will describe the principles where we have to tailor-made, customize and applied according to patient's presentation. So airway, when we are assessing the airway, my main aim would be to see first thing whether it's patent or not. So if it is patent, the second one will be whether patient is able to maintain the patency or not. So those are the two questions I should get answers at the end of my airway assessment. So how to assess? You go and talk to the patient. So if you talk to the patient, you ask his or her name. Then if they are answering, it means patient's airway is patent. So there is air circulation going through the glottis. And their lungs getting aerated because some oxygen is going to brain. So lung function is not that bad, like not imminent death. There can be some underlying disease, but the patient is having some degree of oxygenation. Then this oxygen is transported to brain as well. So it means some degree of perfusion is there. And the brain is functioning as well. So patient talking and telling his name appropriately. Like if the patient is rational, it indicates like there is airway patency as well as some degree of good quality breathing, circulation, and disability functioning. I won't say that they are perfect. They may be having some underlying disease, but it doesn't mean that they are impending death, right? So it's very important to see whether the patient can talk and whether they are rational. If patients are confused, like then there is problem. There can be certain causes for that. We will come back to later. Come into later. So the first thing is I said patent or not. So if patent, then whether they can maintain or not. So sometimes these patients with low GCS, their airway is patent, but they cannot maintain the patency of airway. That is a problem. Lucky. Something to do with Zoom. And again, yeah. So in that case, we may need to support their airway to maintain the patency. So that is different compared to obstructed airway. Patency is there, but there is a possibility of difficulty in maintaining. So that is a different entity due to low GCS, could be due to low GCS. In that case, we have to go for like airway maneuvers and sort of to see whether they can maintain. Now, I'll restart it in now. Sure. Right. So if the patient is unable to vocalize properly, then you have to assess the airway. So this is how we assess the airway. We look for the possibility of airway obstruction. Like you look for any secretions. It can be vomitus. It can be blood. It can be some broken teeth. So you open up the oral cavity and look for the airway, any secretions or any foreign bodies. Then you listen. You listen for noises. It can be gurgling. Gurgling noises occur because of some secretions. Can be snoring. Snoring, the commonest cause is tongue falling back and obstructing the oropharyngeal area. So what you have to do is you give a jaw thrust to open up the airway. Especially these patients with low GCS, they are losing their upper airway muscle tone. So obviously the pharynx, they don't have any bones, so they will be collapsed. So tongue will fall back. So that will cause like partial obstruction. It's not an actual obstruction. It's a partial obstruction. So you need to relieve by giving a jaw thrust. You have to look for hoarseness, change in voice that indicates something to do with vocal cords. That is a trouble. Like we have to anticipate imminent airway obstruction. Then stridor. Stridor is the features of upper airway obstruction, which indicates some problems at glottis level. So we have to secure airway in that case. So that this is how we identify. First, we see whether the patient can talk or not. If there is a problem with talking, you have to, can be due to like some other cause. So you have to look for the airway patency, like secretions or anything. Then listen for noises. And put some face mask oxygen. Yes, I know oxygen can kill, especially in ICU setup, but from critical care point of view, like in acutely ill patient point of view, give oxygen high flow. It is a must. So with airway, you put some oxygen and start high flow oxygen. So we on airway adjuncts. So if there is a partial obstruction, you need to go for airway maneuvers like good old head tilt, chin lift, and jaw thrust. And you can use oral airways or nasopharyngeal airways. And in case if there is a possible impending airway compromise or there is a like actual airway obstruction, you need to go for intubation. I'm not going to discuss in detail. So how to do a jaw thrust, very important. I don't think majority must be knowing this correctly. So you have to take your pinky fingers and put it behind the angle of mandible and push this mandible towards anteriorly. This is how it is done. So then only this tongue will move forward anteriorly and you can open up the airway. So you can see you have to put your fingers behind the angle of mandible and pull it forward, right? And this is how to place oropharyngeal airway. We know you have to put it inside and rotate 180. If you put the curved side up and upwards, it will push the tongue inside and block it more. So make sure you put it correct way. Okay, so breathing assessment. The principles of breathing assessment is to identify the respiratory distress, whether patient is in respiratory distress or not. So what are the components of this? We are worried, I will be worried about the effort of breathing and efficacy of breathing. So how to assess the effort of breathing? By patient's respiratory rate, whether patients are tachypneic or bradypneic, both are important. All extremes are troublesome features when it comes to emergency. And use of accessory muscles. How, like the abdominal breathing pattern, the depth of breath, how deep breaths, whether patients are taking deep breaths or shallow breaths. So those are effort. Then when it comes to efficacy, you have to measure the pulse oximeter saturation. Then bilateral air entry, even though whether patient is breathing, whether the air is conducted into the lungs. So that is the efficacy. So keep that in your mind, like these are the things you have to look for. Your aim is to identify respiratory distress. So you will be thinking of effort of breathing and efficacy of breathing. When you assess these parameters, you will get an idea what is the cause. Like if patient is coming with breathing difficulty, then with this assessment, at the end of assessment, you will come to a diagnosis like, okay, this may be a pneumonia, this may be asthma, this may be a pneumothorax. So it's the good old respiratory assessment where you look for trachea, look for chest expansion, you look for percussion and everything you have to do, but you do it in a quick manner. Aim is to identify the effort and efficacy to decide the degree of respiratory distress. And the management of breathing will be depending on the cause. Yeah, so warning signs will be tachypnea, bradypnea, difficulty in completing a full sentence, agitated or comatose. If they are agitated, it means they are trying to breathe and keep them alive. If they are going down the hill, they will be like quiet and giving up. So they are at imminent risk of death. So it's very important if patients are quiet and not struggling, it's a trouble, right? And cyanosis and saturation and you know this stuff, right? Okay, so we have assessed the airway, it's patent, patient doesn't have any problem to do with the airway, then you assess the breathing, that looks all right, then you go for circulation. So the aim of assessing circulation is to identify the level of perfusion. That is the aim. So what is shock? PMD. What is shock?
So is the vascular inadequate tissue perfusion and inadequate waste product, inadequate excretion of waste product.
Yes, yes. So it is inadequate tissue perfusion. So when you are assessing circulation, you should always remember you are trying to identify whether the perfusion is adequate or not. So your aim is to identify whether the patient is in shock or not. So these are the 4 types of shock: hypovolemic, cardiogenic, obstructive, and distributive. So this is good old med school medicine. Out of these, distributive shock, it is like they are having peripheral vasodilation. So the skin is warm, the pulses are bounding. So just because you feel a good pulse doesn't mean that patient is not in shock. They can be in septic shock with low blood pressures even though the pulses are bounding. So distributive shock examples are like sepsis, anaphylaxis, and even neurogenic shock. So that was like a vasodilatory shock. But all other shock types, they cause vasoconstrictive shock, where patients are having cold, clammy peripheries. So the CRFT will be prolonged. The skin changes are different compared to distributive shock. But all 4 types will be having tachycardia and hypotension. I have seen if the blood pressure is low, we are very worried. But if tachycardic and not normal blood pressures, we are not that worried. It's wrong. It's wrong. So this patient, every patient, when they come, they try their maximum to stay alive. Each and every system, they try their maximum to stay alive. So this is the important step: compensated shock versus uncompensated shock versus irreversible shock. So initially they will be compensating with the circulatory collapse. So they will be having tachycardia, but blood pressure is normal. So if you see, unless it is distributive shock, the pulse, the diastolic blood pressure is going up because of the vasoconstriction. So pulse pressure is narrow. That's why in dengue, we are very worried about pulse pressure. That is compensated shock. If you fail to identify that, patient will go into decompensated shock. So it's very important, like patient, when you see, this patient is sick, tachycardia, skin is very cold, clammy, they are vasoconstricted, look very sick. It means that patient is about to give up. So compensated shock, intervene. If you identify and intervene, but unfortunately, if we miss or if they come late, they will be like decompensated shock. At that time, the blood pressure is low. So just because blood pressure is normal doesn't mean that patient is not in shock. They can be in shock, which is at compensated state. So it's very important. I have seen several times, not only in this hospital, during like even from the internship and sort of. So very important to know that. If we miss the bus at decompensated shock, what will happen is cellular acidosis leading to systemic acidosis and enzyme deactivation, and all the biochemical goes down. And